Morning, everyone. Thank you for joining today's webinar. Today's webinar is about hidden inequality, the importance of accurate ethnicity recording and rigorous reporting. I'm Chung. I'm the data analyst in Population Health Management team, and David.
Hi, I'm David. I'm the senior data analyst in the Population Health Management team.
Thank you, David. Before we start, as we want to make this webinar interactive, I would like to ask you to join Menti. If you can use your phone or your browser, you can type in menti.com and use the code 17866856, or use the QR code on the screen.
Has everyone managed to get onto Menti okay?
Just pop in the code in chat as well. Anyone wants to copy and paste it into. I've also shared the link to menti.com in the chat, just for anyone that's using it on their computer.
Thank you, Dr. First answer. To learn more about stats, and you're at the right place because we will talk about stats today. I will go on to the next slide. So what we're covering today, we'll separate this webinar into two parts. The first part is by me, which is the missing ethnicity data. I will cover why it's important to report ethnicity, and I will present how complete are the ethnicity recorded in different NHS healthcare data sets, and what methods can we use to deal with missing ethnicity data. The next part will be presented by David, and he will talk about why are statistical confidence important in reporting, and how do we estimate uncertainty, and the challenges when we face small groups. So, if you rate your knowledge about today's topics, how confident are you in these topics we're covering today? Responses, 6 responses. Yes. Hopefully today's session will help you to boost your knowledge and get you more confidence in these topics. So I'll go on. So why is ethnicity recording important? So the reduction in ethnic health disparity has been a key focus of the UK government since the Race Relations Act in 2000. And it is essential to monitor and carefully plan the healthcare services, which aim to reduce health inequality gap among these ethnic groups. In the later slides, I will demonstrate the existing gap that we found in our projects, namely diabetes and the pregnancy outcomes projects, which we found a significant health inequality gap among ethnic groups. And the next thing is the cost, is that ethnicity recording is incomplete across different NHS data sets. I will also have a slide demonstrating the incompleteness across different data sets. And the consequence of incomplete data set is that it poses significant challenges when it comes to effectively addressing and planning service to reduce the gap among these ethnic groups. So this is one of our projects, which is diabetic risk factors for NHS health checks attendees in Birmingham. We used a 5 years rolling data from 2018 to 2023, which we have around 10,000 observations in the data sets. And we can see, and we use two types of analysis in this one, which is the population attributable fraction. It indicates that how many negative events could have avoided if the health check attendees have the same level of risk as the reference groups. And here the reference group is white ethnicity who lives in IMD Queenhouse 3+ area, which are the least defined area. You can see from the left-hand side, Asian Black mixed has the highest proportion of negative outcomes. We can see the Asian in diabetic range, in diabetic outcomes, 317 cases could have avoided if they had the same risk as our reference group. The right-hand side is a regression-based analysis, and we're reporting in relative risk ratio. These two negative outcomes are relative to individuals who are in normal condition. So we can see that Asians, Black and mixed, also have elevated risk comparing to the white ethnicity. Another project we are currently working on is the wider determinants of health of birth outcomes in Birmingham. We also use the same methods, which is the population attributable fraction and also a regression-based model. And we also observe a similar pattern, a similar gap between this ethnic group. We can see from the left-hand side, Asian, Black, Middle Eastern, and mixed also have higher risk of experiencing or delivering like low birth weight, premature and stillbirth. One thing I want to point out is that in this data set we also experience missing ethnicity. Look at the first line. This slide. In this analysis, which we use methods which I will be introduced later, which are imputation to deal with the missingness. And in the maternity birth outcomes one, we grouped the missing ethnicity into unknowns, and we can see that from the unknowns group, they are also having an elevated risk in this negative outcome. This slide presents the missingness across NHS dataset. We see that the community service dataset has the highest rate of missing, which we have 30% of unknown ethnicity in the datasets. Emergency care dataset and A&E is around 8 to 9%, and inpatient and outpatient is around 5 to 7% missing. What approach can we take to deal with this missing ethnicity? As a data analysis point of view, I am suggesting 4 today. The first one is linkage to additional dataset. Second one is name recognition software. Third one is information of ethnic distribution. And the last one is multiple imputation. Linkage to additional datasets is by far the easiest way to deal with ethnicity missingness. Imagine you have your dataset which have missing ethnicity on the left-hand side, which is the red table. You have missing ethnicity in your dataset, and the easiest way to deal with it is if you have available access to additional data sets. For example, this additional data set may have better ethnicity recording, and you may be able to link them by using unique identifier. In this case, NHS number is the unique identifier. And once you link them together, we can see that your missing ethnicity could be solved by the additional data sets. The next method is information of ethnic distribution. It's also a fairly easy method to deal with missingness. It requires information about geographic areas. Imagine you have a data set which you have the LSOA, which is the lower super open areas, the LSOA code in your data set. And in this area, you have missing ethnicity. And you can go on census to find out the ethnic distribution of the specific LSOA you're looking at. For example, in this LSOA, the ethnic distribution of white cohort is 60%, and the others are 10%. So when you are trying to complete the missing data, you will randomly assign the distribution. So we have 10 missing in your data set. So we will randomly access 6 white ethnicity, 1 Asian, 1 Black, 1 mixed, and 1 other in the missing rows, which the completed data set, assigned data set will be on the right hand side. The next method is called name recognition software. Neither David nor I are experts in this software, but we're just out of interest to present to you that it is an available method. And I will just very briefly go through. And this method uses different techniques and build the classification decision trees to classify your name. And these techniques include CEL triage. CEL stands for cultural, ethnic, and linguistic grouping. And this is a method that used to identify clusters of names that has cross occurrence in first or last names. So one example is that if David names is put into the decision tree classification, then David will be classified as British if most of the David's barrier also have a British last name. And next thing is spatial temporal analysis. I'm not going through demographic analysis. Text mining. Text mining is all about like analyzing the components, letters of your name. For example, if your names consist, first name consists like A, B, D, then you may classify it's more like a Muslim origin. So you may be classified as Muslim individuals from the classification tree. The last method is imputations, also called multiple imputation. In simple terms, it is to use what you have in your data sets to predict what you do not have in your data set. So for example, we have a data set, and obviously we have missing ethnicity. The way to predict and impute the missing ethnicity in this data set is to by employing a stochastic regression-based model. So if you're missing is ethnicity, in this equation I've shown ethnicity will be your left-hand side, and your right-hand side is the variable just to predict ethnicity, which are gender, age, and outcome. Once your equation is made or written, then you can create multiple copies of this data set by using these equations, and each data set will have slight difference by incorporating randomness, and this will be done by the software. And the next step is to predict your target outcome, and which is also called outcome in this data set. You will write another regression equation, which is the outcome on the left-hand side, and the variable of interest, gender, age, and ethnicity. At this stage, ethnicity will be imputed in this estimation process. The last step is just to pull the estimates from each of these regression model on each of the imputed data sets. So after I introduce this method, do you have any thoughts of what are the pros and cons of these methods? Yes, that's true. Yes, these are just predictions, estimates. Yes, the imputation model can be very complex. And yes, the imputation method requires a lot of technical, requires you to have statistical knowledge and technical skills in coding. And yes, bias. There's always bias when you have mixing data. Yeah. So we can no further restriction. Okay. Yes, systematic reasons for not recording. This could be explained in other terms of like missing not completely at random. So the data might not be missing completely at random or missing at random. So you might introduce bias again. Yeah. This is a summary tables of the pros and cons of the methods I just introduced. So for linkage to additional data sets, it is very easy to perform. But the cons are your additional data sets may not be reliable at all. There are still missingness in your additional data sets. And one thing is you need a unique identifier to link the data sets. In this case, or in our case, we are not given a unique identifier. The NHS number are not given in our data set in any of our projects. So we cannot use this method in our projects. So the next one is information on ethnic distribution. It is also very easy to carry out. However, it requires us to assume the ethnic distribution of the area is an accurate predictor. And we also need to have the postcode or LSOA of the patients, which in our case, we do not have that too. The next thing is name recognition software. It is a detailed classification of people's origins categories. And the software is updating, is continue updating, and it's called OnnoMax, and you can go on their website. And it's available at individual level or UK postcode level. However, it does not perform well to identify Black, mixed and Chinese or other ethnicity historically, and it is demonstrated by this paper Ryan et al. 2012, and it requires application to gain access to the software. You have to write a research purposes apply to use this software, and it will be useless if you also do not have the names of the patient, which in our case we do not. And the last is imputation. It is a powerful statistical tool, and uncertainty is managed in imputations as we introduce randomness in each copy of the imputed data sets. It can be flexible in simple or complex imputation methods. For example, you can use mean or median or mode imputation, but I do not recommend. It is accessible in most statistical software. SPSS data are It's all available. And however, it requires reasonably good amount of statistical knowledge. And you also need to know how to code in this software. Unfortunately, none of this method provide 100% accurate because these are all estimates. The only way to obtain reliable statistics is all parties put together, including the healthcare staff, including the government, the system, and also the patients themselves. And there are strategies that we can take to improve the completeness. And I suggest the first one is patient involvement. It is a wide-ranging consultative exercise with various minority groups, so wording and ethnic group response options. This is to avoid pitfalls when we are providing or asking minorities their ethnicity to, when we're asking the minority groups for their ethnicity. The next suggestion is boosting collection by providing intensive training to staff and the knowledge to inform a clearer reasons for collecting ethnicity to patients and convey in appropriate spoken and written language. Another method is to standardize data collection protocols across sectors, because there are often variation across hospitals or GPs when recording this ethnicity data. So if you're interested in the methods, you can go on to these links for more in-depth understanding of the methods. So I will hand over the time to. I will let you share.
Thanks, Chung. Let me just swing full screen. Yeah, thanks a lot for that, Chung. Okay, so now I'm going to be talking about the other side of the sort of ethnicity related studies, and that's ethnicity reporting. So let's start with an example. We have a situation here. We're looking at the number of people with some disease, ominously called X, per 1,000 residents. So we have the number per 1,000 residents, which group is at greatest risk. Now, I'm sure there's one answer that's jumping out at you. Keep that in mind, and we'll come back to this question in a little bit. So whenever we're doing any kind of analysis, any kind of statistical tests, we almost always only have a sample of the potential data. And so for example, the NHS health checks, only a sample of people will actually turn up for that health check. It's normally in Birmingham, much less than 50% of the people eligible will turn up to the health check. So it's only a sample of the population. And even if we do have an ability to measure the whole population, for example, with the census, very close to the whole population, the answer may actually be different the next time we measure. And so, for example, again, in the case of diabetes, we may have an understanding of the percentage of the population that has diabetes one year, but that actually is subject to change in the next year. And so there's a level of uncertainty in every measurement that we make. And this isn't just about ethnicity, differences between ethnicities. This is also between any group. You can think of investigating. And so as an example, let's imagine that we have a sample of 10 people from the population and we test them for some disease. And our we sample them initially, and we find that 5 out of 10 have the disease. So we'd say there's 50% of them would have the disease. There's a rate of 50%. But actually, as we repeat this measurement, as we repeat our sample, we see that the percentage of people with the disease changes very significantly. The probability of people having this disease has actually stayed the same across time. I can tell you that for certain because I set up this simulation. But actually, the percentage of people with the disease has changed very significantly. And this is because our sample is so small, the uncertainty is very, very large. Similarly, you can imagine flipping a coin 10 times and getting heads 8 times. That doesn't necessarily mean that you've got a biased coin. It might just be that that's how, the probabilities happen to work that time. Your coin is still 50-50. Let's imagine another example of having 100 people with the same disease rate, and we repeat our measurement. And we see now that the percentage still changes every single time we measure. But since our sample size has increased so much, the uncertainty has decreased. There's much less variation in the percentage. But it's important to note that this uncertainty will never be zero. There will always be an inherent uncertainty in this measurement, in this percentage of people with the disease. So now we come back to this question: who is at greatest risk here? Well, obviously the answer you're probably leaning to is the Black African cohort. But once we take into consideration the uncertainty in our measurements, certainly in these proportions, it gets a little bit more complicated because, of course, the Black African cohort still has been measured to have the highest percentage, but it becomes much more difficult for us to say with certainty that the rates for the Black African group is significantly higher than the Black Caribbean group. You might be able to say it's higher than Black other, but again, now we can't say with statistical certainty that the rates for Black Caribbean are higher than Black other. And so it's important to do our sort of statistical due diligence and calculate these uncertainties before we make any claims about the differences in rates between different groups. So how do we calculate uncertainty? Well, typically we're thinking of confidence intervals, which I've labeled here as CI, and these are equal to the proportion of your people, so the percentage with the disease, plus or minus some error. So again, we can now imagine a point on a graph with some error bars, and the point represents the proportion of positive cases. So I've got here little n divided by big N, so the number of people with some disease divided by the number of people in your study, and then plus or minus this uncertainty, this error called E. Now, how do we calculate E? Well, there's a formula for that. Don't panic. You know most of the components here. So the value P is just the proportion of positive cases that we saw earlier. So if we have 16% of people with, again, keep coming back to the example of diabetes, then this P is 0.16. And then we have the size of our sample or population that we're looking at. And then we have this mystery value Z. Now, what does Z mean? Well, Z we get to choose. And we choose Z depending on how confident we want to be. So, for example, if we want to say that we're 90% sure that the value lies between this range, then we use a value of 1.645. If we want to be 99% confident, then it's 2.58. So we see that as we want to be more confident, our Z value increases. And so therefore our uncertainty, our confidence intervals also increase because we need to take into consideration a larger range of values. And so typically we tend to use a value of 1.96. So we're typically looking for confidence intervals of 95%. Now, I know some of you might be thinking, I want to be 100% confident. I want to have the best statistics in the world. Well, we can calculate what Z value will give us 100% confidence, and actually it comes out to be infinity. Why is this? Again, because every measurement we have has an inherent uncertainty. And if you want to contain all of the possible values for the true value of that measurement, you have to essentially have an infinitely large error bar. Now, in reality, often our values can't go to minus some positive infinity. So, for example, if we're looking at percentages, what percentage of a population has some condition, it's obviously bounded by 0% at the bottom and 100% at the top. But again, if you want to be 100% confident, if you're 100% confidence level, then your error bar is going to go from 0 to 100. So this is why we have to limit ourselves to some high level of confidence like 95%. So we'll go through an example of calculating this. So imagine again, coming back to the example that Chung was talking about earlier, NHS health checks, so screening program for individuals aged 40 to 74. And among other things, patients are tested for diabetes. Now, a local authority like Birmingham may receive data on all the patients, including this may include their ethnicity and whether or not they have diabetes. So an example, we're just going to consider two broad groups of Asian and white, and our data might look something like this. We have the number of people that have been seen at an NHS health check and the number that are diabetic. And so now I want to calculate the proportions and the uncertainty on those proportions to see if there's a difference and whether that difference is significant. So we extend our table to add proportions to P for proportions, E for uncertainty. So calculating the proportion for the Asian cohort, this is the easy part. We take our little number, the number with diabetes, 354, and divide it by our big number, 2,235, and we get a proportion of 0.16 or 16%. Next, we want to calculate the uncertainty. So we're just plugging the values we already know now into this equation. So 0.16 for P, 2,235 for N, and we use a Z value of 1.96 because we want the 95% confidence interval. And we see that we have an uncertainty of about 0.02, so 2%. We go through the same process for our white patients. So calculate the proportion. 196 people with found to be diabetic divided by 3,355. Proportion of about 0.6, so it's much lower. And then we calculate our uncertainty. And here now we see that the number of people that attended a health check is quite a bit larger than the Asian patients. And so our uncertainty ends up being a little bit smaller because we have this, we're dividing now by a larger number of people. We see that uncertainty is decreased, uncertainty estimate. So you can do the mental math to determine whether these overlap. If you're not so good at that, it's much easier to see when it's graphed out. And now we see the percentage of patients with diabetes. So the percentage of Asian patients with diabetes is much higher than the white patients. And actually, you see that these confidence intervals aren't overlapping. So we can say that with a level of with statistical significance. We can have statistical certainty that this is a true difference. We can repeat that for then other groups, as shown here, and now we can start to compare the real differences between these groups. Now, in this example, we've used quite broad definitions. That's an artifact of the way that ethnicity is recorded in the GP data set. It's essentially a free text box, and it gets very difficult to relate some of the answers to the standard NHS definitions. But ideally, as I think it was Monica said in the comments, we want to look at as specific a group as possible. So in this case, we're looking at census data. So in the census, one of the questions that was asked was, how good do you think your health is? How good do you feel your health is? And here we're looking at the percentage of people in Birmingham who said good or very good. And we see there are some differences between these broad ethnic groups. So they're written out a little bit more fully, but essentially they're the Asian, Black, mixed, other, and white groups. And you see there's some differences, and we'd be forgiven for missing the fact that there is actually an error bar on here. But because our populations are so large, because we're looking at the whole of Birmingham, the error bar is very small. So that gives us confidence then to say, okay, maybe we can look at some smaller groups. So we might want to look at the more specific groups. We see the error bars have increased slightly. So some of the differences become more difficult to distinguish, for example, between British and the Gypsy or Irish traveller. But what we can see now is there are some important differences that we wouldn't have picked up before, such as the fact that the percentage of people reporting good health amongst African residents is much higher than Caribbean residents. Similarly, we see lower levels of good health in Irish residents compared to British. And so these differences are only possible to find if we take the time, find the data to drill down to these specific groups. However, there is a caveat, because as we drill down, our uncertainty grows. As the groups that we're looking at, the size of the groups we look at decreases, we become more. There's an increase in the uncertainty of our statistics. And so here we have another example where we're looking at the percentage of people with some specific condition, and the calculated percentage for each of our Black ethnicities is higher than our white ethnicity, but our uncertainty is very, very large on each of them. And what that means is that when we sample again next year or next month, actually the answer might be much lower, and we might find that these groups don't have a higher rate of this health condition to the white cohort. So what can we do instead? Well, one thing we can do is to aggregate these up. I see that, yeah, there's overlap in confidence intervals, so we can't say with certainty that there's a difference between the proportions for these groups. And so that's why sometimes it does become important to aggregate up so that we can recover the inequalities that do exist, and say with statistical rigor, with certainty, that there is a difference between these groups, that the patients with Black ethnicity have significantly higher rates of this health condition than those with the white ethnicity. So to summarize, we saw earlier from Chung that ethnicity reporting is improving, but still has a long way to go, particularly the community services dataset. There's large amounts of unknown ethnicities. There are a number of methods to improve completeness, such as combining multiple datasets, name recognition software, imputation, and improvements in data collection. Forgot to fix that. We need to be very cautious of statistics that don't include uncertainty estimates, particularly when we're comparing groups. So for example, if we may see reports and figures saying that one group has 25% rate of some disease compared to another group with only 20%, if they haven't included any level of uncertainty in those values, we need to be very cautious before interpreting them as hard and fast facts. And uncertainty falls as our data sets grow. So as we look at larger and larger groups, the uncertainty on our values decreases, but it's never zero. And the other point is that, if we want to drill down to them as specific groups as possible to uncover the hidden inequalities, but as we do so, our uncertainty will increase. And so there may be times when it becomes no longer helpful to drill down to these very, very specific groups if the statistics we're getting out are no longer rigorous and no longer useful to us. So that's an end of our presentation. Just before we move on to questions, give you another opportunity to let us know how confident you're feeling about these topics. Do you feel that you've learned something from today, even if it's just the overall ideas related to the topic? Perhaps you've uncovered issues within this that you've never thought of before, and actually it's bigger than you realized, and so you feel less confident. Yeah. How are we feeling on that? Is everyone still able to access the Menti? It's not changing for me.
It's changing in Menti. You want to reload it. Try to
Okay.
You
I need to
hover on your. If you hover on the slides.
Here we go.
There is a right arrow. Yeah, okay.
There we go. Okay, excellent. Much higher. Want to continue changing? Oh, every time I click, it changes. Okay. Anyway, it seems to be moving now. So, just as a sort of related aside, it does look like the more of you are confident than before. So that's really promising. Although, is that increase statistically significant? We'd have to plug our values into the equation to find out. But hopefully they are. Hopefully you found today useful. So thanks a lot for listening. I'm struggling to exit out of this now. There we go. I'll stop sharing my screen and we'll have a chance for questions.
We haven't got any in the chat, so has anyone got any to ask now at this point? All good then. So we can give you back 15 minutes of your diary. Thank you, everybody.